Good morning, everyone. Today we'll be talking about pit and fissure sealants. Introduction. The prevalence of occlusal caries in children is a significant dental health problem. The anatomical pits and fissures of the teeth are the most susceptible areas for initiation of this dental caries. Occlusal sealants are considered as effective caries reducing agents. Proper patient selection and application techniques are followed. Now, how do we define a pit or a fissure? A pit, as per defined by Ash in the year 1993, is a small pinpoint depression located at the junction of developmental grooves or at terminals of those grooves. As you can see in the picture here, the next is fissure, which was defined by Obbins in the year 1954, which says that they are deep clefts between the adjoining cusps. They provide areas for retention of caries-producing agents, which, if not cleansed, will cause more and more of bacterial attack. Now, according to caries classification system, a non-cavitated or initial lesion can be defined as initial caries lesion that develops before the cavitation occurs. So, non-cavitated lesions are characterized by any change in color. You can notice a change in the color, glossiness, or surface structure as a result of demineralization before there is a macroscopic breakdown in the tooth structure surface. So, what is a pit and fissure sealant? We've been talking about sealant application. So, what is a pit and fissure sealant? This is a term that is used to describe a material that is introduced into the occlusal pits and fissures of caries susceptible teeth, thus forming a micromechanical bonded protective layer cutting access of caries producing bacteria from their source of nutrients. Another definition that was given by Matthewson for occlusal sealants is defined as the application and mechanical bonding of a resin material into an acid-etched enamel surface, thereby sealing existing pits and fissures from the oral environment. According to ADA, it is an adhesive material that is applied to pits and fissures of teeth in order to isolate from the rest of the oral cavity. So going back to the history of sealants, they say that from 1895, there were various authors, there were various scientists who worked on this, and their contribution has immensely led to the development of the recent pit and fissure sealant. So 1895, Wilson, he placed zinc phosphate cement in pits and fissures, which was later taken over by Hyatt in the year 1923, in which he contributed prophylactic odontomy. In 1929, Bodecker introduced fissure eradication. 1955, Buonocore said that sealing of pit and fissure with bonded resin material was much effective. Again, in 1967 and in 1970 and in 1971, furthermore materials were introduced in the form of cyanoacrylates, which is later utilized by BIS-GMA with ultraviolet polymerization. And again, the first commercial pit and fissure sealant, that is the Nova Seal, was developed in the year 1971. So coming to the morphology of pits and fissures. They are composed of reduced enamel epithelium. If you know the stages of tooth formation, the reduced enamel epithelium, along with microbes and debris, they provide protected niche for plaque accumulation. So how do we classify pits and fissures? This classification was given in the year 1961 by Nagano as V-type, U-type, I-type, IK, and inverted Y-type. You can see in the pictures here, the shallow white B and the U-shaped fissures. These are the ones that tend to be self-cleansing and somewhat caries resistant. Whereas when there is a deep, narrow I-shaped and K-shaped fissures, they are quite constricted and resemble a bottleneck. So there is a more chance for plaque retention in such kinds of fissures. Why are pit and fissures highly susceptible to caries? Bacterial and nutrient harboring capacity. That is the main thing. Then close proximity of its base to the dentino-enamel junction makes it more prone to develop pit and fissure caries. Total inaccessibility of these areas to any mechanical means of debridement is another cause. So when there is a bacterial accumulation or when there is a plaque accumulation, if the area is not properly being able to be cleansable, then they act as an nidus of bacterial attack. What is the potential role of pit and fissure sealant in primary and secondary prevention of caries? When we think from a primary preventive perspective, effectively penetrating and sealing these occlusion pits and fissures with a dental material. For example, we said pit and fissure sealants. They can prevent lesions and is a part of comprehensive caries management approach in pediatric dentistry. From a secondary preventive perspective, that is, sealants can also inhibit the progression of non-cavitated caries lesions. The caries is progressing, but we need to stop them so that they further don't cavitate the lesion. How do you classify pit and fissure sealants? So now based on the curing method, we have generations. In that, we have first generation, which has ultraviolet light activated, 350 nanometers of polymerization or incomplete polymerization. Example is Nuva light. Then we have the second generation sealants, that is self-cured or chemically cured. For example, you have concise white, which is being used. Then you have the third generation, that is visible light cure of 430 to 490 nanometers. For example, we have HelioSeal. The fourth generation sealants are fluoride releasing sealants. When I say fluoride releasing, they impart karyogenic or anti-karyogenic property. They act against the caries and they form fluorapatites. So, for example, we have Sealant. Again, the next classification we have is based on the presence of filler. That is, they can be either unfilled or they can be filled. The advantage or the properties of an unfilled filler is that they have better flow and more of retention. But they abrade rapidly, which is one of the drawbacks. Again, when we use a filled filler, a filled sealant, it is strong and resistant to wear and may need slight occlusion adjustments before you cure it. Now, based on the appearance or color, we have clear sealants, we have tinted or opaque sealants, and we have colored sealants. When I say a clear sealant, it means it is aesthetic but difficult to detect in a recall visit. It almost simulates that of the color of the tooth that is naturally present. Example is HelioSeal, which changes its color from green to white. Again, in tinted or opaque, this can be identified even after the placement. For example, you have Delton sealants. Then we have the colored sealants that is easy to see during placement and recall visits. We place a sealant and we recall the patient in the next further appointment and you will be able to appreciate the sealant. The one that we used in the colored sealant is the Clint Rose sealant, which changes to pink color on setting on polymerization. The next classification is based on the chemical nature of the monomer that is used. We have MMA, that is methyl methacrylate. We have TEGDMA, that is triethylene glycol dimethacrylate. Then you have bis-GMA resin, that is, it is a reaction product of bisphenol A and glycidyl methacrylate with a methyl methacrylate monomer. Based on the fluoride release, you have fluoride releasing sealants, that is FISSURE F, and you also have non-fluoride releasing sealants. Now, what are the indications and what are the contraindications for a sealant application? We have certain criteria on the basis of which we select a tooth that is indicated or contraindicated for a sealant application. The first criteria that we see is the tooth age. Okay. When considering the tooth age, we see that there is a indication, that is, it should be a recently erupted tooth that is prone to or susceptible to caries. Whereas a tooth that is contraindicated for the same sealant is a tooth that remains caries free for more than 4 years and the one which has not been fully erupted. Again, when we take occlusional morphology, sealants are indicated when there is a deep, narrow, retentive pit and fissure, and also contraindicated if there is a narrow, wide, self-cleansing pits and fissure which need not be given a sealant. We consider the status of proximal surface. It is indicated when there is a sound status or the proximal tooth is sound. Again, it is contraindicated when the adjacent teeth is caries. Then we see the general caries activated. Many occlusion lesions and few proximal lesions are present, then you can indicate a sealant. Whereas it is contraindicated when there is many proximal lesions. Other preventive measures, we indicate sealant as a preventive measure. Okay, that is, the patient receives systemic and topical fluoride therapy and are still caries active. Now, when we talk about the patient selection, the age period for sealant placement, okay, ages 3 and 4 years are the most important times for sealing the eligible deciduous teeth, because this is the time when they'll be chewing. The molars will be used for chewing. They would have had eruption of all the deciduous dentition. It will be a pure primary dentition. Again, ages 6 to 7. That is for the first permanent molars. It is at the age of 6 to 7 years that we see the eruption of the first permanent molars into the cavity. Again, ages 11 to 13 years. That is when the second permanent molars and premolars erupt into the cavity. So they are more prone to exposure to bacteria and retention. So you need to be careful. Now, the evidence-based recommendation endorses that adults as well as children should receive sealants when the tooth or the patient is at risk of experiencing caries. The question of whether to place a sealant over a fissured surface should not be based on how long ago the tooth has erupted. But when you see that there is an initial caries, or when you see that there is no self-cleansing pit of fissure, you can place a sealant. It should be based on the clinical impression of whether a sealant is necessary to prevent caries, as I said. We do a caries risk assessment. You need to know that how, at what level of risk is the child or the tooth that has been exposed. So this is the likelihood of the incidence of caries during a certain time period. Patient should be evaluated for overall caries risk. Individual teeth should be evaluated as well. Again, there were various studies that was done for this. Okay. Heller and colleagues studied caries progression in sound teeth with and without sealants, and in teeth with incipient caries lesions with and without sealants. Based on the caries risk, it was categorized as Group 1, Group 2, and Group 3. Now, Group 1 is the caries-free patients that are judged at no risk to decay. Group 2, we have patients judged to be at moderate risk to decay. And Group 3 is the patients with rampant caries at high risk to decay. This classification was given by Simonson in the year 1983. So how do you diagnose occlusal caries? We have been saying about pit and fissure caries. We have been talking about the severity, indications, contraindications. So how do you diagnose an occlusal caries? It is the first and foremost thing when a patient comes to you is you do a visual examination alone. Clean, dry tooth is sufficient. Okay, you can detect the earliest caries lesion. When you look into the patient's mouth itself, you can see it visually. Again, caries is present when the explorer, you use a explorer, the shepherd's crook, and you run over the occlusion surface of the tooth. So if there is a catch or it resists removal after the insertion into a pit or fissure with moderate to firm pressure, you suspect that there is a cavitation or there is an occlusion caries. Again, this will be accompanied by softness at the base of the area, opacity adjacent to the pit or fissure, and the enamel will be softened adjacent to the pit and fissure.